Many people are aware that speech language pathologists work with articulation disorders or even adults who have lost language because of strokes. But most people are unaware that speech language pathologists work with children and adults who experience problems with their voice or the vocal mechanism. This section will focus on voice production and treatment of voice disorders. In Chapter 2, we talked about the anatomy of phonation. We described the cartilages that make up the larynx. Let's review. In the front of the body, we have the large thyroid cartilage that sits atop the cricoid cartilage. And at the back of the larynx, we find the arytenoid cartilages that sit on the cricoid cartilage. These structures serve to protect the vocal folds and also serve as an anchor point for the origin and insertion of muscles that are responsible for producing sound. The vocal folds are actually the thyroarytenoid muscle, and they attach to the back side of the thyroid cartilage. That's located in the front of your body. And towards the back of the body, the vocal folds attach to two protrusions of the arytenoid cartilages. The vocal folds open and close as we breathe and as we produce sound. Think about how complex our vocal folds are, how they're able to change the shape and the tension to produce different sounds. You can make animal sounds, you can imitate transportation sounds. Think about ventriloquists and what they can do with sound. Think about impersonators and how all these different sounds they can make and change their voice to all these different tones of other people. The vocal folds are actually a multi-layered structure. These different layers include an outside layer that's just like the skin in your mouth. The middle structure consists of kind of a jello-like layer. Then there's a rubber band layer, a cotton string layer. And finally, the thickness or the bulk of the vocal fold is made up of what we call the thyroarytenoid muscle. It's the relationship between that outer layer, which is like the skin inside your mouth, and then the cover, which is the jello-like rubber band layer, interacting with that cotton string layer and the thyroarytenoid muscle, which is the body, that enables us to produce a normal sounding voice. So it's the interaction of all these layers with each other that allows us to produce our normal voice. When changes occur to these structures, we first perceive a difference in the person's voice and then perhaps the presence of a problem. So perception comes first. Now we're going to examine different characteristics of normal voice and then look at disordered voice. So in order to understand what disordered is, we have to know what normal is. When we describe a person's voice, we examine vocal characteristics on a perceptual level, and then we relate these characteristics to the underlying physiological properties. The first characteristic that we will talk about or describe is pitch. Pitch is related to the number of vocal fold vibrations produced within a given period of time. If I ask you to take a breath and say ah, we could actually analyze the average number of times that your vocal folds are vibrating per second while you're saying that sound. So you say, ah, we hear pitch, but what's actually happening is how many times your vocal folds are vibrating within a given period of time. So we can measure that. This is called the fundamental frequency. It varies from individual to individual. What affects your fundamental frequency is the vocal fold thickness and length. So for example, if your vocal folds are really thick and short, it's going to be a slower fundamental frequency. It's going to be like 125 cycles per second, for example, for a male. They have shorter and thicker vocal folds. And then a female is going to be 225 to 250 hertz. And children are going to be even faster because they're thin. They've got thinner and longer vocal folds, so it's going to be like 400 hertz. The second characteristic we're going to look at is loudness. Loudness is the perceptual characteristic of an underlying physiological property, and that property is intensity. It's associated with the amount of subglottal air pressure that is built up prior to producing the sounds. Also, the degree of the vocal fold tension and the length of time associated with vocal fold adduction, which is meaning the closing of the vocal folds. So we might describe someone's voice as too loud or too soft. But we're really looking at the intensity, which is the pressure that's built up, how much the vocal folds are tensing, and the length of time associated with the closing of the vocal folds. And lastly, we'll look at resonance. That's the third characteristic of voice. Resonance is how the sound produced by the vocal fold vibrates in the pharyngeal, oral, or nasal cavity. So depending on where the sound resonates, we might describe a person's voice as hypernasal, which is too much resonance, too much air, or like he has a cold, or denasal, or hyponasal. So like right now, I sound like I have a cold. I'm cutting off the air to my nose. There's less air, so it's hyponasal. Hypernasal is when there's too much air. The fourth characteristic of the voice is the vocal quality, and it's associated with resonance and also laryngeal tension. When a person uses his or her voice with too much laryngeal tension, we might say that person's voice is rough or breathy. It is often excessive use of voice and associated tension that result in changes in vocal quality. So there can be something that's called vocal abuse that might cause this tense or breathy vocal quality. So let's look at some voice disorders. So there are two professionals who can diagnose voice disorders: the ENT, ear, nose, and throat specialist, or also called the otolaryngologist, and the speech-language pathologist. And even though these professionals are able to measure the frequency of vocal fold vibration or the intensity of vocal output, the way that we really find out if a voice is normal versus abnormal is when all these perceptual factors come together to produce that unique voice quality or unique voice of the individual. So the listener can make a determination regarding the person's voice based on hearing the voice. So we have a number of definitions of voice disorders that relate to our perception of the characteristics. Aronson, 1985, reported that a voice disorder exists when quality, pitch, loudness, or flexibility differs from the voices of others of similar age, sex, and cultural groups. That's a quote on page 168 in your book. So, when one or more aspects of the voice, such as loudness, pitch, quality, or resonance, are outside the normal range of age, gender, or geographic background of the speaker, we say that a voice disorder exists. ASHA defines a voice disorder by the abnormal production and or absence of vocal quality, pitch, loudness, resonance, and or duration, which is inappropriate for an individual's age or sex. Voice disorders occur across the lifespan. They can affect children or adults. We know that school-age children, 3 to 6% exhibit voice disorders, and 3 to 9% of the entire population exhibit a voice disorder. The prevalence, or how many people exhibit the problem at one time, amongst teachers has also been investigated. And teachers exhibited almost double the number of voice problems compared to non-teachers. Why do you think that is? Probably because they're talking all the time. They're using their voices excessively. It's also determined in that same study that women exhibit greater numbers of voice problems compared to men. Women do talk more than men, so that can have something to do with it. Or women might be in professions where they have to talk more than men, that kind of thing. The National Center on Voice reported that 24% of U.S. population have jobs that critically require voice use. So we recognize that many people, a healthy voice has economic and communicative implications. So let's begin to look at voice disorders and how we classify them. First, we're going to talk about phonotrauma. Phonotrauma is an umbrella term, and it covers a lot of different types of vocal behaviors. Traditionally, vocal misuse or vocal abuse have been used to describe what we're now calling phonotrauma. Phonotrauma suggests a relationship between the vocal behavior, changes in laryngeal tissue, and the resulting voice problems. So when we talk about phonotrauma, we'll see that there's an inappropriate vocal behavior, and it also leads to change in the laryngeal tissue that will then be perceived as a change in the person's voice. So the first disorder caused by phonotrauma, or the behavior, we'll call hard glottal attack. And what that is you may hear someone exhibit abrupt, hard stops to their speech when initiating vowel sounds, and it can lead to more chronic problems or changes in that laryngeal tissue. Puberphonia is often in males. You can hear it with men that have gone through puberty but continue to use those higher pitched voices, so their voice hasn't lowered. The problem could be emotional and physical. Persistent glottal fry is a vocal behavior that some individuals have, and it sounds corn popping or the sound of a motorboat engine. It's kind of that crackling in your throat, and even though normal speakers can have this at times, I know I've had it at times, if it's habitual or happens most of the time, that's when it's considered disordered, or there's maybe a problem there, and it can happen. Those people usually complain of vocal fatigue or a monotone voice. Also, excessive talking could result in changes of voice production. There are some people that can talk for 3 hours or 4 hours and it not even affect their voice, but there are others that can talk for many hours and then they can report that they have pain or they feel fatigue in their voice, or their voice is now monotone, or they're hoarse. So it can result in changes of voice production. Excessive talking can. Excessive and prolonged loudness can be a problem, and it's often associated with a number of jobs and activities. For example, teachers or clergy, people that work in factories that have to speak over loud machinery, coaches that have to yell over a loud environment. If you think about an SEC football, for example, those coaches are having to talk really loud on the sidelines. And I've heard some of those coaches' voices on videos, and they sound like they've been abused, or they've had some vocal abuse. You can hear that breathy, hoarse quality. Children who scream excessively. People who attend sporting events who yell and scream. Individuals often experience vocal fold tissue changes in association with these behaviors. Cheerleaders, for example, who scream and yell all the time. Another phonotrauma or change in laryngeal tissue is traumatic laryngitis. So, for example, if you've gone to a football game and you've screamed your head off and you've stayed up all night singing, and then all of a sudden you wake up the next morning and you can't get your vocal folds to work, you're experiencing what's called traumatic laryngitis. It's resulted from the screaming or yelling or talking loud. So if we looked at your vocal folds, we would see that they were red and swollen, and they're not vibrating as efficiently as they typically do. Because those tissues are swollen with fluid, they don't vibrate as fast. So you sound like you have a lower pitched voice. It sounds really dry. Sometimes it can occur as a result of smoking cigarettes, because that dries out the vocal folds, or even drinking a lot of alcohol that dries out the vocal folds. It absorbs into the bloodstream, the alcohol does. And as the alcohol is exhaled during respiration, it has the potential to dry out the vocal folds. So when consumed over the long term, it can cause permanent damage to the larynx. So if you ever have seen someone who's maybe an alcoholic or a heavy smoker, you probably have seen a change maybe in their voice. For most cases of traumatic laryngitis, where because the person has screamed too much or at a ball game, the vocal folds will return to normal after a period of vocal rest. If you drink a lot of water and you rest your voice. But when an individual does not rest his or her voice, that traumatic laryngitis can become more persistent or even a chronic condition. So if you've seen someone that abuses their voice over time and then they end up changing their voice quality because of that habitual abuse. Vocal nodules are another result of phonotrauma. They are described as benign or non-cancerous growths on the vocal folds. It is believed that these nodules come as a result of vocal abuse, and it appears when the vocal folds are swollen. Vocal nodules can be on one vocal fold, which would be unilateral, but more chronic vocal nodules appear on both vocal folds, which is called bilateral vocal nodules. It is very common for individuals to try to compensate for their breathy, hoarse voice by increasing their loudness, and that increases the tension in the larynx. And while that may help you in the short term be louder, it's going to cause further strain on the vocal mechanism, causing those vocal folds to push harder together, resulting in further development of the problem. Treatment of vocal nodules is a controversial issue because speech language pathologists believe that behavioral therapy to teach the client good vocal hygiene or modifications in their laryngeal behavior will eliminate the nodules. But otolaryngologists, they want to a lot of times remove the nodules or perform surgery. And the speech pathologist sometimes will argue that that might make matters worse because you're changing the vocal folds and it might cause more problems. Because if they don't modify their behavior, then they're going to come back and they're just going to have more problems. Another problem resulting from phototrauma are vocal polyps. Polyps are also benign laryngeal growths, and they occur in the same location as nodules, about 1/3 of the way up on the vocal fold. But the difference is they often occur on one vocal fold, a polyp will, and they remain soft and pliable, whereas the nodules are hard. Polyps often occur as a result of a single laryngeal event, such as loud yelling at a concert or a scream during a horror movie. Like just all of a sudden, you've created some trauma for your vocal folds. So some blood vessels may break on the surface of the vocal fold at the point where the fold makes frequent contact. So then those vessels are surrounded by bodily fluids, and then they form into this growth, or what's called a polyp. So you've probably seen or heard about polyps other places. So that can also happen on the vocal fold. So remember, it's usually on one vocal fold. For some individuals, if they feel that polyp on their vocal fold, they may want to cough or clear their throat, but a lot of times that can make things worse by rubbing those vocal folds together. Voice therapy can be successful at eliminating polyps for many clients. If clients require surgery, a period of voice therapy before surgery may help them be more aware of certain behaviors that may cause the problem in the first place. There are two neurological disorders that we'll discuss that affect the voice. One is vocal fold paralysis, and the other is spasmodic dysphonia. Vocal fold paralysis affects the vocal fold's ability to open or close. So in bilateral adductor paralysis, the vocal folds are paralyzed open, so they cannot close. So you can imagine that this would be life-threatening. A person may choke, they can't produce sound, they're at risk for aspiration or inhaling fluid or liquid into their lungs, can lead to pneumonia or death. And then in abductor paralysis, they can't open their vocal folds. So they can't breathe because they can't open their vocal folds. So respiration is the primary concern. So they may have tracheotomy so that they can breathe. The most common type of vocal fold paralysis is unilateral vocal fold paralysis, where there's only one vocal fold that's paralyzed. And this can happen with trauma or disease. So one way trauma can happen is if something hits the neck. So if you've noticed in recent years, catcher's masks for baseball players and hockey masks for the goalie have been changed so that they can protect the neck, so that the puck or the baseball can't hit the trachea or hit the larynx right at the throat. So that's something to note because of injury or trauma to the vocal folds in years past. Spasmodic dysphonia is a condition where the patient exhibits a lot of struggle and strain when they're attempting to talk. Some patients exhibit a choked voice quality or a voice that sounds as if it's squeezed. It's a neurological problem that's characterized by excessive laryngeal adduction. So the vocal folds are closing excessively. Treatments include injections of Botox into the laryngeal nerve to provide relief and stop the muscles from spasming. There continues to be questions regarding those botulinum toxin or Botox injections because the symptoms do return after a period of time, so the relief is only temporary. We will now talk about voice disorders associated with organic diseases. These include granulomas, papillomas, and carcinoma, or cancer. Granuloma is an inflammation in the body caused by tissue irritation. This can be caused by a tube inserted into the lungs during surgery, which may cause some roughness on the vocal folds as the tube is going in. It'll cause some irritation to the vocal folds. Also, GERD, which is gastroesophageal reflux disease, can cause this irritation to the tissue and cause granulomas. Another name for granuloma is a contact ulcer. It's a type of granuloma. This can be associated with people who use their voices in a forceful manner. Treatment for this problem has included surgery for the patient's gastroesophageal reflux disease or the GERD. It's also that's helped and resulted in the elimination of those granulomas once the GERD is under control. The next voice disorder is a papilloma. It's described as a wart-like growth caused by a virus, and it can result in obstruction in the airway. Juvenile papilloma is the most common form of laryngeal tumor in children. These papillomas are usually removed by surgery. There can be scar tissue left over after the surgery, which can result in voice changes such as hoarseness, low pitch, breathiness. Many children, as they get older, can develop a resistance to the virus, and those papillomas can go away. However, depending on how many surgeries or the location of the papilloma, the patient can be left with a permanent voice disorder. And finally, carcinoma, which is cancer or laryngeal cancer. One of the early warning signs of this is if there's persistent hoarseness for more than 2 weeks. Cancer often occurs within the vocal tract, but more specifically on one or both vocal folds. If it's left untreated, it can become life-threatening. Cancer of the larynx has been associated with smoking, environmental irritants, metabolic disturbances, and other causes. So how do we assess voice disorders? Well, a speech-language pathologist must work closely with an otolaryngologist, also known as an ENT. Sometimes this evaluation can happen with both professionals at the same location. Sometimes they may work in 2 different places, so the client may have to go to 2 different places to have a complete assessment. The evaluation includes an extensive case history, finding out as much information about the person's history and behaviors. Also a client interview, asking a lot of questions about the client's voice, listening to the voice, observation of the laryngeal functioning, acoustic and physiological testing. And we will talk about this a little more in depth in the next few slides. One thing to note, before a speech-language pathologist can begin treatment of a voice disorder, the client must have medical clearance from an otolaryngologist. So a doctor must see a voice client before a speech-language pathologist can begin treatment. So it's important that you work closely with this other professional. So when you're interviewing the client, it's important to ask the person to describe the problem. If the patient has already seen a doctor, then they can give you information from that visit and tell you what's already been done or what's already been noted from the physician. If the patient begins to describe their voice and tell them the problems that they've been having with it, the SLP will ask several behavioral questions, such as tell me about how your voice sounds. When did the problem happen? When did it start? How long have you noticed it? Is it a persistent problem or does it come and go? What are some of your habits? Do you have a job where you use your voice a good bit? How does the voice problem affect your job? How does it affect your daily activities? Is there any smoking in your home? Do you smoke? Do you take medication? What's your relationship of your voice with other people? What's your academic history using your voice? Any information that will help you get a well-rounded picture of the person and how they use their voice and how the voice problem is affecting their life. In addition to the interview, the larynx must be viewed. So the ENT may view the larynx, or you may view the larynx with the ENT, or you may have access to be able to view the larynx. There are several different ways to view the larynx. One is direct laryngoscopy, which is a very invasive procedure where the patient has to be put to sleep. There's indirect laryngoscopy, where the doctor wears a circular mirror on his or her forehead, and the circular mirror directs the light towards a dental mirror that he or she is positioned at the back of the patient's throat. During this process, the patient is holding his tongue or her tongue with gauze and pull the tongue and epiglottis forward. The tongue is somewhat immobile because of that, and so the dental mirror is resting on the person's tongue. The doctor can actually ask the patient to say "ah," and so they can the doctor can view the function of the vocal folds with the mirror. During the past 30 years, technology has been developed that enables physicians and speech-language pathologists to view the larynx during periods of quiet breathing, singing, continuous phonation of sounds, and conversational interaction. Using a flexible fiber optic nasolaryngoscope or fiberscope, you can see on page 178, and there's a picture of one here, the bottom of your PowerPoint. The fiberscope is a flexible bundle of glass fibers that has an eyepiece or camera, and you can actually view the vocal folds and what they're doing. To view the cycle-to-cycle opening and closing of the vocal folds, the examiner might use a video strobe light or stroboscopy that can be set to pulse at a variety of frequencies. While stroboscopy can be done with a flexible fiberscope, some examiners report better results with a rigid fiberscope. You can see that in this picture to your right. It resembles a small telescope. During laryngoscopy, the physician and the SLP are trying to determine how the patient's vocal folds move and also observing the characteristics of the laryngeal tissue to determine if there's any pathologies. They're also having them do a number of vocal activities like raising and lowering pitch, producing loud and soft voice, sustaining phonation, and producing conversational speech. During these activities, examiners will record the person's speech so that the acoustic signal can be analyzed. So they'll look at the fundamental frequency, the variations in frequency of vocal fold vibration, ability to vary vocal loudness, and other vocal characteristics. Additionally, the examiner can use equipment to measure physiological activity associated with the vocal folds opening and closing and respiration. So when all these measurements have been completed, they can evaluate the results, look at the interview, the laryngeal examination, the acoustic, and the physiological measurements, and determine the nature of the client's problems. Voice assessment as well as voice treatment is a very complicated process, and you can go much more in depth in this in your other communication sciences and disorders voice classes. We will now talk about treatment of voice disorders. Since voice disorders vary according to age of client, the sex of client, their treatment's going to vary as well. The goal of voice therapy is to restore the best possible voice that can be used for functional purposes of employment and general communication. So sometimes we're teaching in therapy the individual how the system works and the effects of excessive behaviors on that system. So for example, we're teaching them vocal hygiene and how to take better care of their voice, such as drinking a lot of water or vocal rest or not using their voice excessively or inappropriately. There's something called vocal fatigue, so we might teach them when vocal fatigue may occur in their lives, what they can do to prevent that. So we're increasing the client's awareness of their inappropriate vocal behaviors and educating them so that they can improve the quality of their voice and making sure that they can incorporate it as part of their lives. So for example, if we're treating a professional singer who has abused their voice, or a salesperson or a teacher, and we have to teach them some strategies or some things that they can do to take care of their voice. You may have heard Taylor Swift or another famous singer who's gone on vocal rest, so they've canceled their concert because they have to take care of their voice, because they may have vocal nodules or they may have some phonotrauma to their vocal folds. Some teachers may use a microphone or some other device to help them not abuse their voice in classroom. Some helpful hints for a healthy voice include drinking a lot of water, avoid excessive or frequent throat clearing, avoid excessive coughing, avoiding reflux by taking medication or having surgery, getting plenty of sleep. Fatigue can cause voice to sound hoarse. Use plenty of breath support. Make sure you know how to breathe when you're speaking. You're using that diaphragmatic breathing, not the shallow breathing, the clavicular breathing or phonatory breathing. Do not speak in sentences that are too long, so you may need to break up your sentences so that you have good breath support. You minimize caffeine or alcohol or dairy intake, because it can dry out the vocal folds and create thick mucus. Menthol throat lozenges can dry out the throat Smoking is very damaging to the vocal folds, can irritate them, and also can cause cancer. Be aware of background noise. So raising your voice above others in a loud environment, just screaming at a ball game, or if you're at a concert trying to talk to a friend over loud music. Watch your volume and the posture of your head and neck while you're on the telephone. This can cause uneven pressure and strain on the vocal folds. If it seems that speaking takes extra effort, or you have throat discomfort or pain after using your voice, or you're experiencing cracking of the voice, you need to see an otolaryngologist or a speech language pathologist. So you want to make sure you're taking very good care of your voice. Another treatment approach is something called alaryngeal communication, and it's a term that means without a larynx. So sometimes people who have cancer to the larynx, they may have to have structures removed that prevent them from using their vocal folds for communicating. So they have to have their larynx completely removed. So their trachea is repositioned, and there's a stoma, which is a hole in their throat that's created for them to breathe. If the patient no longer has larynx or no longer has vocal folds, then they have to have another source of vibration to produce speech. So there's something called an electrolarynx or an artificial larynx, and it can be held up to the throat, and it creates some vibration and allows a person to speak through this electrolarynx. It sounds kind of robotic-like when they talk. The drawback to these devices is that the quality of the voice is kind of robotic or monotone, but it is a laryngeal communication. Another form of alaryngeal communication is called esophageal speech, and this is where a person is learning to use air in their esophagus to speak. So it almost sounds like a burp. So if you've ever heard somebody kind of speak as they're burping, they're using an esophageal speech. You're not speaking with your vocal folds. You're using that air and the esophagus to actually speak. So some people can be trained to do this because they don't have a larynx to communicate. So there's also a procedure called tracheoesophageal puncture, and that helps the patient direct air from the trachea to the esophagus in an easier manner. So with that method, the patient's able to put a finger over that stoma, over that hole, and it forces air back through the special tube in this esophagus. Sometimes this procedure happens at the same time that the laryngectomy happens, so that the person can go ahead and start learning how to speak in a different manner without their larynx. So having a larynx removed is extremely traumatic for patients, but knowing that there are different forms of therapy or different ways they can restore their voice can be positive for patients. So you as an SLP would be a part of that counseling and that training of how to use their voice in a different manner.